Welcome everyone who pours into our virtual room. It's great to have you all here. Thank you for joining. I wish I could see all of the attendees, but thank you for being here. Miigwech, Masi Cho. Oh, it's a full house in there. Thank you. Welcome everyone to our Ontario NEIHR monthly webinar. I'm Dr. Suzanne Stewart, also known as Etsy in my language, Clicho. I'm from the Yellowknives Dene First Nation, a visitor and longtime resident here in Toronto, Haudenosaunee and Anishinaabe territory. I'm the director of the Waakabeness Institute in Indigenous Health Research, and I'm here to welcome and host this amazing Ontario Network for Environments and Indigenous Health Research webinar with our very exciting and wonderful and thrilling speaker, Dr. Cornelia Wieman from First Nations Health Authority. We also have in the room here are our elder in residence, knowledge keeper Clayton Shirt, who I'm going to put down tobacco out here under a tree. As you can hear, I'm outside with the birds singing in nature. And so, Clay, could I ask you to kindly open us up with a spiritual prayer, and then I will introduce Dr. Wieman, and then we can get started. Thank you so much, Clayton. Gitchimigwich. Again, I'm Dr. Suzanne Stewart. I'm from the Yellowknives Dene First Nation. I'm the director at the Waakabeness Institute for Indigenous Health Research at the University of Toronto, and I'm a part of the Ontario NEIHR, which stands for Network for Environments in Indigenous Health Research. And I'm very thrilled and honored to be here with Dr. Nell Wieman, whom I've known since I first came to U of T in 2007. She was very warm and welcoming to me as new Indigenous faculty when I joined U of T. Dr. Wieman is the Chief Medical Officer at First Nations Health Authority in British Columbia. And she's been in that role for quite some time, for over 5 years, since 2018. She is Anishinaabe, and she has the distinction, and this just thrilled me when I first met her. I was kind of awestruck, so I was probably a little quiet and shy. You may or may not remember, Nell, at the time. I was pretty overwhelmed to meet you because you were, and maybe still are, I don't know, but Canada's first Indigenous psychiatrist. And with that distinction, she has over 25 years of experience in leadership in both Indigenous mental health and health, both in community and in academics. And she's worked in many different settings over the last 25 years. And she was one of the people who actually founded the National Consortium on Indigenous Medical Education. And so she's a real trailblazer in Indigenous mental health, and I don't want to talk too much about her many accomplishments because I could use the whole time to just talk about all the things she's done and what a wonderful person she is and what a great mentor she has been to me since I met her 18 years ago. Although neither of us have aged at all since we met in 2007. In fact, Nell has aged backwards, as I was remarking when we saw each other here, and we saw each other last summer too at NAMR at McGill. So I'm going to stop chatting. I'm going to turn off my camera, and I'm going to hand everything over to Dr. Cornelia Wieman, and to give her great thanks and great honor and great privilege that we have to have you here. So Masi Cho.
Buju and Megwich Suzanne, and to Elder Clay for that opening. I'm really happy to be here with all of you today. So while I get started, I'm just going to share my screen and super hope that that works. There we go. So hopefully you can see my slides, and I'll just get going. So I wanted to start again today by acknowledging Elder Clay Shirt. It's always a privilege to do any kind of work alongside elders. So I'm really appreciative of that opening, and also thanks Suzanne for that introduction. Now, Wieman Indigenous, Anishinaabe Inda, Mishipuitic Indunjaba, Musqueam Squamish Tsleil-Waututh Inda. In my language, I have told you that my name is Nell Wieman. I am a member of Mishipuitic First Nation, which is in Treaty 5 territory, part of the Anishinaabe Nation. I live on the traditional, ancestral, and unceded territory of the Musqueam, Tsleil-Waututh, and Squamish nations. As Suzanne mentioned in my introduction, I am the Chief Medical Officer at First Nations Health Authority, and so much of what I'm going to share with you today is some of our collective work that myself and my team in the Office of the Chief Medical Officer and other teams across our organization have done in the area of research with the goal of improving mental health services and health services in general. We really are working towards transforming the health system here in what is colonially known as British Columbia. So I'm going to take you through a bit of a presentation. I'll keep an eye on the time because I want to open it up for questions. Suzanne?
I was so excited to talk about how amazing you are that I forgot the housekeeping announcements I was
Oh.
supposed to make at the
Go
beginning
ahead.
of this. First of all, we have a feedback form that we'd like to invite all the participants to fill out at the end. It'll be dropped in the chat. It's very short. It helps us to be relevant and deliver the kind of webinars that y'all want to see. And secondly, this is being recorded, so just so that everybody knows that, and it's going to be archived on our YouTube channel, the Wakabanes YouTube channel, so that any one of you can go watch it again, or Dr. Nell, you can use it in any of your classes or for promotion or for any reason that you want to use it, just to make that clear to everyone. And lastly, we have a survey that's nothing to do with this presentation that we at the Ontario NEIHR are doing a survey for Indigenous people or any healthcare providers who work with Indigenous people. After the presentation, we'll drop that in the chat if anyone wants to do our survey. So, miigwech.
Thanks, Suzanne. So one of the things that I wanted to share with you as I go through some of these slides is I have a habit of including a lot of different links to different kinds of information and reports. And I did not, before this presentation, share a PDF copy with Shanti. So I will do that right afterwards. So if anyone wants a copy of the slides, they are more than welcome to them. And so you'll see here, I have a variety. Also in my presentations, I love to take photographs and I love to use them in my presentation. So this is one of my favorite parks in Vancouver to walk in. It's called Pacific Spirit Park, and there are many very large cedar and Douglas fir trees. And so it's always so good to get even out on the land in that sense of get to a large park and be able to just be in those big among those big trees and hear the birds and everything. So if I did include a link here on how to, if you want more information about land acknowledgements, territory acknowledgements. As part of looking forward about where we're going in our work and in our research, it's always important as well to look a little backwards and recognize the people on whose shoulders we stand. And for me, when Suzanne mentioned that, you know, I was the first female Indigenous psychiatrist in the country, that was when I finished my training back in 1998. The first Indigenous psychiatrist in the country was Dr. Claire Brandt. I'm not sure how many of you have heard of him. He died about over 30 years ago now. He was Wolf Clan from Tyendinaga Mohawk territory. And he actually died when I was in my second year of my residency. And I never met him in person, though I heard a lot about him from other Indigenous physicians. And so I really missed having that mentorship from him. And probably it is another reason why I'm so committed to mentorship now and in my own career. So we remember Dr. Claire. The other thing I think that underlies when we talk about wanting to improve mental health services, the health system in general, we can't not talk about racism. And that underlies not only why the health system is unsafe for First Nations people, but why some of our health outcomes are so poor. So people may be aware that in British Columbia in 2020, in the late fall, we had a report come out that was called In Plain Sight, that interviewed thousands of Indigenous people, First Nations, Métis, Inuit, and made several conclusions. One is that racism is still widespread in BC's healthcare system, and it limits access to services. And this is really an important issue to be aware of, because when we talk about access, we're not just thinking, oh, someone lives rural or remote. They're far from service, so they never get as much care as they could be if they lived in an urban center. That's partly true here in British Columbia, which is primarily a rural, remote, and isolated province. But access is also when people choose not to go to those services, even if they are available. And we know that one of the reasons why people choose not to go to seek services is because they have an expectation that they will be treated badly. And so on the bottom left of your screen, you'll see links to the full In Plain Sight report. There is a shorter summary report if you're interested in reading through that. And then there's quite a long data report that accompanies both of the others. But the graph that I want to point out, and it's something for all of us with an interest in mental health and mental health services, is when the participants were asked, what are some of the settings in which you don't feel safe at all? Not at all safe. Mental health settings were in the top 3. So you'll see mental health clinic, hospital social worker, mental health and substance use services. So this really tells us that we have a lot of work to do. The other thing I think that people maybe need a bit reminding about is that the health system has been set up in such a way that it already is embedded with systemic racism. And so it's working exactly the way that it's meant to. And when I talk about health system transformation and what we're trying to accomplish here in BC, in part of our work in First Nations Health Authority and with our partners, is that we want to change the way that that system is working and serving, in this case, BC First Nations. And I just want to remind the audience that a lot of the time I'll be using First Nations in a distinctions-based way. I try to avoid the use of Indigenous, mainly because it's pan, it includes the 3 major groups, and I work for First Nations Health Authority, so that's where I'm situated. So just looking at this slide, there's a lot here to unpack, and I won't spend too much time on it, except that we know that prior to contact, First Nations people enjoyed good health and wellness outcomes. And then there were some, there were the terrible historical, contemporary, genocidal impacts that also impacted on the healthcare system. And so that the circle in the middle talks about people's experiences in the healthcare system, so that Indigenous and First Nations people are stereotyped once they enter a healthcare facility, they're labeled as automatically as drinkers, alcoholics, drug seeking, frequent flyers, bad parents, etc. And then those racist stereotypes lead to discrimination. So that's the change in how people are treated in a substandard manner so that their pain is not treated appropriately. I hear stories almost weekly from First Nations people here in BC that sometimes it takes repeated visits to the emergency department in order to get their particular problem actually addressed. And then it negatively impacts access to healthcare, like I've talked to about. It's not just having a place to go, it's feeling comfortable and safe in being able to go there. And of course, if you're not seeking treatment for a health condition or you're not being able to access the proper treatment for your health condition, it leads to poor outcomes. And so that breaking the cycle at the top right of the screen talks about that return and the working together of Indigenous and First Nations systems, traditional healing, being out on the land, participating in healing ceremonies and different practices. And so the very picture at the top right, these are two elders that I work with quite a bit here at First Nations Health Authority. The woman is Elder Sequoia, who calls me sister friend, and I just love her so much. I just saw her yesterday morning at a meeting. And then the fellow on at the very top is Sulkson, who I just participated in a very important ceremony involving our provincial minister of health and her team. I also want to acknowledge before I share some of the work that we've been doing at First Nations Health Authority that there's a lot of work happening across this country. And I have not necessarily included the work of the Ontario NEIHR because I'm sure you've had many presentations on that, but to highlight some pieces that have come out, especially most recently. So there has been work, for example, in Alberta around First Nations versus non-First Nations people in Alberta who leave emergency departments without completing treatment, or what we call against medical advice as physicians. And and that phrase against medical advice almost is a victim blaming phrase where it's like, well, you know, as the physician, I told people what they needed to have, or I've prescribed a treatment plan, and they left despite me saying that they needed to stay longer, or things like that. It's this very shifting of blame onto the patient, where in fact people may have left the emergency department because of the care that they're receiving, the type of care, the disrespect, the racism, sometimes the pain that they are that's inflicted upon them. So there are many reasons why First Nations people choose to leave the emergency department. And then most recently, just I think last week or the week before, in Manitoba, Dr. Marcia Anderson, who's also a colleague and friend of mine, led a team that studied emergency department visits and the care that they received in a public report that was just launched. And the purpose of this report was to measure access to and quality of care so that gaps could be addressed. And what they found was using race-based data is that Indigenous patients present with similar triage scores to white patients, meaning it counters the common stereotype that Indigenous people use emergency departments inappropriately. So for example, the thinking is, you know, well, First Nations people are unattached to family doctors, and so they just use the emergency department like a family doctor. But in fact, how they're scored in terms of the acuity of their presentation is similar to non-Indigenous people. and that Indigenous and Black and African patients wait the longest to be seen in the emergency department as part of this report. And of course, Manitoba was the place where Brian Sinclair died waiting to be seen in an emergency department, which was several years ago. Some of you may have heard of that particular tragic case. The other thing that we need to keep in mind is that when we are undertaking what we call research, that research has not always been culturally safe. And here in British Columbia, there is a very well-known example. Some of you may have heard about it. This goes back many years now, 2 or 3 decades, where a researcher, Dr. Richard Ward, worked with the Nuu-Chah Nation under the guise of wanting to study rheumatic diseases, including rheumatoid arthritis and other conditions. And so something like 883 First Nations participants from this nation consented to participate in this study. They gave blood samples, which were collected and kept by this person, this Dr. Ward. He never actually returned, well, the blood samples have been repatriated since then, but it was many decades. But he never actually returned a report to the community or never fed back knowledge about what he'd learned as part of this study. There was a scientific publication that came out of that particular work. However, what ended up happening was he took the blood samples. He moved initially to the United States and then I think to England, took them with him, and then proceeded to do some genetic anthropological studies, which was a secondary use of the samples, and something that the First Nations people of Nuu-Chah Nation had not consented to. And so this was, again, another, egregious breach of research ethics. And the blood samples were also lent to other researchers to conduct similar genetic anthropology studies. So this was the memory of this experience looms large here in this province. And so there's always a lot of work that we have to do to build that trust, to work with First Nations people on different aspects of research and different topics. So I'm just going to share our vision. So every organization has a vision, mission, etc. So our vision is for healthy, self-determining, and vibrant First Nations children, families, and communities. And so we are guided by what's called the 7 directives. And the very first directive that all of our work is driven by is that it be community driven, nation based, and be participatory. So we have over 200 First Nations communities here in British Columbia, and we work with different nations and groups of nations, family groups. For example, BC is divided into 5 regions. The interior region has 54 separate First Nations, but seven overarching nations. So for example, the Ktunaxa Nation has 4 First Nations that belong. And so we rely on community members to tell us the things that they see as priorities and what they would like to see, the types of research that they would like us to engage in. And of course, we have to adhere by First Nations ethics, data governance protocols, and OCAP. So I'm not going to go through every single bullet point on this slide, but just to kind of bring home the point that we want to conduct research that is meaningful, and we spend a lot of time on knowledge translation activities in a variety of different fashions, and we are in a fortunate position where we have pretty defined data governance protocols. So for example, in my office, one of my major roles as the chief medical office is called the Watchman. And I wish I had included a picture here. I'm just thinking of it now. So if you picture in your mind a totem pole, everybody probably knows what a totem pole looks like. Carved wood, can be quite large. There are certain kinds of totem poles here in British Columbia where there are typically three heads at the top, at the very top. And the three heads all look out in different directions. And the top of that is called the Watchman. And so they are usually that totem pole is usually placed at the entrance to a community traditionally. And the head that looks out sees any kind of approaching danger or risk. And then the three heads at the top of the totem pole chatter amongst each other. And the head that's facing inward, or the heads that are facing inward, warn the community members that something is approaching that could be a risk or a danger. And so that's the kind of metaphor for the role of the chief medical officer and my team, my office here at First Nations Health Authority. So we are the watchmen. And so any kind of data or research that's meant to improve healthcare or the health system in British Columbia must first be presented to BC chiefs and health leaders first. So for example, when we have data that I'll share with you later around the toxic drug crisis here in British Columbia, or what people used to call the opioid crisis, um, I'm always kind of I get asked by the ministry, the provincial ministry of health, like, we need to see your data, we need to see your data, we need to know what's going on. And so I have to say to them, you need to hold on, because we have a town hall coming up where we're presenting the data to BC chiefs and health leaders. Those are the people, the health directors work on the front lines at the community level. We present our data to them first, and then we can release it publicly. And the other thing I'll tell you as I start going through some of this, some of the different projects, and I've only included a few of what we're involved in, is to let you know that we're in a specific, we're quite fortunate in BC in the sense that we have something called the First Nations client file. So we have a linkage, a database where the First Nations band number of an individual is linked with the vital statistics database and the BC client registry, or the health system, the health number that you would use. And so we have this database called the First Nations client file, and we can link it with a variety of other databases. However, we at First Nations Health Authority have control over who is able to access that First Nations client file, and we've been given that responsibility by BC First Nations. And so the client file is controlled by the data stewards. I am one of the data stewards, and then there was a VP of research that included research in her portfolio who has recently left FNHC, so we haven't been able to appoint a second data steward as yet. And I'm not going to go over the concept of two-eyed seeing. I hope most of you are familiar with it, but it's really working in collaboration with Western medical systems, using the best of that system or what they have to offer with traditional knowledges, ways of knowing and being. The only thing I'll point out to you on this slide is the middle picture is where I actually got to meet Albert Marshall in person. And I asked him, is it okay if I use this picture of us in my presentations? And he's like, go ahead. And so I was super happy to meet him that one time. And I am also a nerd. So I've been reading a series of books by a fellow named Siddhartha Mukherjee, who has written a book about the Emperor of All Maladies, which is about cancer. But he also has two books, one about the cell and one about genes. And so I put in this picture of a DNA spiral because it's almost like, those two spirals, the double helix, they are connected by bridges, but the helixes themselves don't touch. So it's sort of similar to the two-row wampum, but people can go up and use traditional ways, and then they can take that little bridge over and use a bit of the Western medical system if they need to or want to. It's all based on self-determination. So we try to respect that and use that principle of two-eyed seeing. I'll quickly mention that in British Columbia, we have developed a cultural safety and humility standard. And this wasn't research per se, but it was more of a review of the literature and a distilling of best practices. But this standard has been gifted to BC's health system, and we have asked that every health and social service in British Columbia adopt this standard. And so you'll see on the left-hand side the different components or chapters of the standard, things having to do with partnerships, leadership, human capacity, health, human resources, quality, cultural safety, etc. And myself and Elder Jerry Ullman co-chaired the technical committee that developed the standards. So it's this lovely picture of Elder Jerry. And then the day that it was gifted to the health system, the members of the technical committee were honored in a blanketing ceremony. So you see the picture at the bottom there. And there is now a national cultural safety and humility standard that's under development. The other thing that I would point out that is available on the FNHA website is a case study reflection. This is a narrative, a qualitative piece of work. It's entitled Remembering Keegan, a BC First Nations Case Study Reflection. And this is Keegan Combs, who died almost 10 years ago. He died an avoidable, preventable death. He was a champion chess player. He was a Royal Conservatory piano player, but he also suffered from a number of different conditions, including at times being nonverbal. And what happened was he had an accidental ingestion of a poisonous substance. He was brought very reluctantly to the emergency department. The paramedics, very culturally unsafe, said, well, we know Keegan, he's a frequent flyer. This is probably, him attention seeking. The proper test to diagnose what he had ingested was not done in the emergency room. And so he died because he did not receive the treatment that would have saved his life in time. And so the picture on the right-hand side, the tall lady, is Rihanna Millman, and she was Keegan's advocate and family caregiver. And so she brought this forward through a number of processes, and our office worked with her to create this case study reflection. And the reason why we didn't call it a case study, but a case study reflection is because it doesn't just contain the narrative of what happened to Keegan, but at different points in his journey through the emergency room and the hospital, we stop. There are cultural safety and humility teachings, and there are also teachings from an elder. And so this case study reflection was gifted back to the Fraser Health Region and to BC's health system. And we have been tasked with having them pick up this work, pick up the recommendations in the report, and for example, figuring out how to incorporate this as an example into the new medical school curriculum, the new medical school that's starting at Simon Fraser University. As part of my work as Watchman, we have this big project called the Population Health and Wellness Agenda. It's a 10-year project initially between our office and the Office of the Provincial Health Officer. So some of you may have heard of Dr. Bonnie Henry. So she is the Provincial Health Officer for British Columbia, so her office. And we have been tasked by BC First Nations to regularly report out on the health and wellness of BC First Nations. And so this 10-year project means that we track 22 health indicators over time. Full reports are due out at year 1, 5, and 10, with interim reports at year 2.5 and 7.5. So we just came out with our first interim report last summer in August, and we did not report on the full suite of indicators. We reported on, I think, 13 or 14 altogether. And these are just some of the ones that are pertinent to mental health and to substance use, which, as you know, when I say mental health, I include substance use in my thinking, because really it's because of trauma in many, many cases as to why people are choosing to use substances in order to try to deal with the distress that they feel. So what we found between the first year 1 full report and the interim report, which was delayed, it was about 3 years after the first report, partly because of the COVID pandemic, was that the rates of youth and young adult suicide actually showed no or minimal change. And so that's not necessarily good news, because even though we have been working on a variety of different initiatives, we are still not seeing a change in those rates of suicide. And we are also seeing no or minimal change in serious injuries requiring hospitalization. And we have seen a dramatic decrease in life expectancy and all-cause mortality rate. And so I'll just show you those graphs really quickly. Sorry. So mortality rate on the left-hand side, the First Nations rates over the years are the dark red lines, and the other residents of BC are the blue lines. And so what you'll see since we started looking at these rates is there's always been a gap. So First Nations have had higher rates of mortality always than other residents of BC. But since about 2017, you'll notice that the graph for First Nations is really going up. And same with life expectancy on the right-hand side, or living long lives that we call it. There has always been a gap where First Nations life expectancy has been lower. But as of 2017, you will see that our life expectancy is even lower. So a difference of anywhere, depending on what time frame you use, between 6 to 7 years lower in terms of life expectancy. And we attribute this to, I've mentioned it earlier, the toxic drug crisis here in British Columbia is a declared public health emergency. We are in our 10th year of this being a public health emergency, and unfortunately and tragically, First Nations people are overrepresented in this population. Part of the indicators of the population health and wellness agenda, though, are what we are developing are more traditional focused indicators. We're working on an indicator that demonstrates connection to land, and that being an indicator of good health. And so we have this joint research project that has been working on developing these indicators called We Walk Together. And there are 3 videos that encompass the work that was done and the work where we are so far. And you can find those on our website as well. And this picture, I love this picture. This is me and Dr. Evan Adams. Some people know Evan. He is one of the deputy chief medical officers here at FNHA and was the former chief medical officer before me. But in the center is a young woman, Dr. Krista Stelkaya, and she was a manager in our office, and she went on to complete her PhD, and now she's a faculty member at Simon Fraser University. And so that mentorship that Suzanne talked about at the beginning it's so great to be a part of Krista's journey and to support her. So we did this study together where we looked at culturally safe mental health interventions for improved mental health outcomes. And really what we found that the key components of mental health interventions that were the most helpful were that they were culturally grounded, included both indoor and outdoor activities, had participation by elders and knowledge keepers, and that peer mentorship that can happen, and participation in collective activities. So we call it here in BC, we use that phrase culture as treatment a lot. And I'm just looking at the time, so I always think I don't have enough slides, and so I add in a whole bunch and then I'm all behind. So I will try to wrap this up. But just to show you the smattering of some of the research projects that we're involved in here, this one was looking at healthcare providers' awareness of traditional and cultural treatments in Vancouver. So we're looking at changing the system by finding out whether typical healthcare providers, so Western healthcare providers, are aware of traditional and cultural treatments. And if not, then encouraging them or providing them with that knowledge and information. So 56 of Indigenous participants in this study felt that their healthcare provider was aware of traditional and cultural treatments, which I think is a big increase from the days, in the early 2000s when I worked in Toronto on the Six Nations of the Grand River Territory. This one is really important. This one is directly related to the toxic drug crisis. And for the first time last year, in 2024, we started seeing a decrease in the total number of First Nations deaths related to toxic drug poisonings. And so that mortality rate graph that I showed you and the decrease in life expectancy is almost attributable to the toxic drug crisis, including a small amount attributed to the COVID pandemic. But this was the first year that we saw a decrease. And so it says to us what we are doing in the area of harm reduction is helping. And further to that, we did a modeling study with the BC Centre for Disease Control, and we were able to use a predictive model to estimate the number of lives that were saved. So between a 5-year period that we studied, we do know that 1,374 First Nations people died of a toxic drug poisoning. But during the same period, using this predictive modeling technique, we were able to estimate that over 1,000 First Nations lives were prevented due to our harm reduction initiatives. And primarily, this was attributed to take home naloxone, the use of opioid agonist therapy, and people having access to overdose prevention sites and supervised consumption sites. This one was a study that we did on what was then called prescribed safer supply. Now it's called pharmaceutical alternatives, but probably not surprising. This was meant where instead of someone accessing the unregulated poisonous supply of substances here in BC, they would be prescribed a pharmaceutical alternative. And so not surprising, the more days that the pharmaceutical alternatives were used, the less likely deaths were to occur. This study, obviously I'm glossing over things now, but to say that we do a lot of research that comes from community, and residents of the northern region really wanted to tell us about how they were experiencing some of these harm reduction programs, like not having them or having a lot of barriers to accessing them. So this is a study that was published, I think this was just last year, in December. And then lastly, the other way that we share information is through these graphic drawings, and this was all around accessing services for perinatal substance use in British Columbia, and the problems that we have, including racism and that terrible history of birth alerts. So all of this to say, all of this research that's ongoing here that we are involved in or partnering on is really meant to improve the health services and the mental health services that we provide. So we have a virtual psychiatry and substance use service that the information gets fed into the the physicians and the allied health professionals that work in these programs, and also into our physical health services, our primary care centers that we're working on developing, treatment centers, and broader than that, we have what's called healing centers, which we're standing up in each of the 5 regions, where they're not treatment centers for substance use per se, but they address that underlying trauma that I talked about earlier. And then this one was just, this is from the population health and wellness agenda. I'm not going to go through every bullet point, but I will say that, you know, we have recommended, especially to the province and to our provincial partners, that there are different actions that need to be taken and sustained to nourish First Nations roots of wellness. And included in that is a principle around research, data governance, upholding principles of OCAP. And so lastly, I just have 2 quick slides. This just got released today. So I quickly made up this slide using some of the research that we've done and that we know. We have developed a toolkit for young people as part of our public health response to the toxic drug crisis. So it's called With Open Arms, and it's directed at First Nations young people, helping them to have conversations with each other around substance use, because we know often young people talk to each other before they talk to anybody else around issues to do with substance use. And so I'll just end by saying this is a picture of Chief Dan George. Some of you may know him in a variety of different ways, but as a member of the First Nations Health Authority, when we joined First Nations Health Authority, we are adopted into the Takaya Wolf Clan FNHA family of Tsleil-Waututh Nation. And Chief Dan George was the chief of Tsleil-Waututh, and his son, Elder Leonard George, was the elder when our organization came into being when we were transferred from Health Canada, and both Chief Dan and Elder Leonard have since passed on. But this is a quote that I love, and it talks about that two-eyed seeing, and that what we're trying to do through our research to transform the health system and result in better health outcomes and overall better health, achieving that vision of healthy, self-determining, and vibrant First Nations lives in the words of and the hopes of Chief Dan George. Like the thunderbird of old, I shall rise again out of the sea. I shall grab the instruments of the white man's success, his education, his skills, and with these new tools, I shall build my race into the proudest segment of your society. And so I just want to say miigwech for your attention. And this is just a picture of my team from a couple of years ago. You can hardly see me. I'm in black as usual. But we were at this giant gathering of our tripartite partners. So anyway, I will unshare, figure out how to unshare, stop share. There. And that was a quick whip around the world.
Wow,
around
thank you. Thank you. So I just want to remind everyone that they can put their questions in the Q&A box, and we have one question. We have questions already, so I'll just read it out loud if you like, and then you can just answer it. And this is from Michael Brown, and he says, I'm curious what the indicators from the Population Health Wellness Report would reveal if they also included positive indicators of wellness. If you were to do this again with wellness indicators, what else would you include now?
Yeah, thanks, Michael, for that question. And in fact, the whole population health and wellness agenda is kind of a living agenda. I mentioned it was 10 years, but we will most likely renew it. The original suite of indicators, as I showed you, are the very typical public health, Western deficit-based indicators. And the work that we are doing, for example, is on through that We Walk Together project. So we are developing, for example, an indicator around connection to land. But the other one that we've been working on is self-determination and how that impacts upon people's health. So I would imagine as we go forward through time that we will be doing more of that work and moving away from the indicators. Although I will say that we do have an obligation right now to report on those indicators, mainly because when First Nations Health Authority came into being, we have these foundational agreement documents, almost like commitments between ourselves, the provincial government, the federal government, to actually report on these indicators. So until we change those foundational documents, we still have to continue to meet that responsibility of reporting on those indicators. But they also tell us something. They are a really, yes, they can be viewed as being very deficit based, but I tell you, the life expectancy that we reported on last August got a lot of attention. And we use that as an advocacy tool. So when I meet with the Ministry of Health in this province, I pull up that slide and I'm like, what we're doing or what you're doing in the area of the toxic drug crisis public health response is not meeting our needs. And we continue to be disproportionately impacted. And so this is like in black and white, what our life expectancy is, and we need to do better. But what I will say, since 2024 and into almost the first half of 2025, is we have actually seen, because I'm not allowed to share the data, but we have seen a good sign that the decrease that we saw in 2024 is continuing. And so I feel positive about that.
That's amazing. Thank you. And that really puts things into perspective of how to work within the system. And that's extremely helpful. Miigwech,
Clay.
Clayton, we're actually running out of time, but there is one other comment in the Q&A that I would like to read out loud. And it's not a question. It's from Dr. Chan Shaw. And it's not a question. He said it's, quote, no, not question, but a comment, a great presentation, and particularly the last quote, which is also reflected in the TRC report. And it's great to see those linkages. And thank you, Dr. Shaw, for being here. And I know he's a big fan of you too, Dr. Wieman. So
It's been a while.
yeah.
Yeah.
So I have a bunch of questions because everything is just like boom, boom, boom. And thank you, Shanti, for putting the reports in the chat for everyone to get. I downloaded all of them, so they're at the front of my screen, and there's so much I want to discuss. But of course, we're out of time, so I'll have to save those for another discussion. Maybe we'll have you back for a kitchen table or fireside chat. That would be great to do that when you get back from sabbatical. And also,
Yeah,
going to put in the evaluation for this webinar into the chat. So please fill that out. We really appreciate it, as well as a link to a survey that the Ontario NEIHR is doing right now around, I know this is a ridiculous question. You're going to laugh when you hear it, but is ACEs appropriate for Indigenous communities as a framework? So so if you're interested in putting in your 2 cents worth about the ACEs framework in Indigenous communities, and you want Ontario Health to know, please fill out the survey. And I will turn it over to Clayton to do our spiritual closing and any concluding remarks, and to say again, Merci Cho, thank you so much. Dr. Nell, for being here. It's such an honor to get all this data, information, your knowledge, your wisdom. I could just talk for hours. So miigwech. And thank you to everyone for being here. It's also an honor to have everyone here in the virtual room. Miigwech.